Hello YouTube, welcome to Dr. Vibes Learning Point. In this video, we'll study about testicular tumors, everything about testicular tumors, and this is going to be a long video. So first, before delving into the topic of testicular tumors, you should know some anatomical points about testis, that is the arterial supply, the venous supply, and the lymphatic drainage. What is the arterial supply of the testis? It is testicular artery, which is a branch from the aorta. And artery to the vas and the cremasteric artery also supplies the testicular artery. So three arteries: testicular artery, artery to the vas, and cremasteric artery. The venous drainage of the testis is from the pampiniform plexus, which drains into the gonadal veins, that is the testicular vein. The right testicular vein directly drains into the inferior vena cava, but the left testicular vein drains into the left renal vein, which further drains into the inferior vena cava. Now let's come to the lymphatic drainage of the testis. Testis has a lymphatic drainage to the retroperitoneal lymph nodes. Now consider this diagram here. This blue colored part is the IVC, the red colored part is the aorta, and the part which I've drawn anterior to it is the vertebrae. Now these circle things are the lymph nodes. So around the IVC you have the paracaval lymph node, and below you have the precaval. Similarly, around the aorta you have the para-aortic, and before the aorta you have the pre-aortic lymph nodes. And in between IVC and aorta there is the inter-aortocaval nodes, and the lymphatic drainage of the testis is to these lymph nodes only. Now the pelvic and the inguinal nodes are the non-regional lymph nodes, and their involvement is only in case of scrotal extension. Okay, so we've studied the arterial, the venous drainage, and the lymphatic drainage. Lymphatic drainage is to the retroperitoneal lymph nodes, the paracaval, precaval, para-aortic, pre-aortic, and sometimes the inguinal group of lymph nodes as well. Now, what are the risk factors for the development of testicular cancers? First of all, 7 to 10% of the cryptorchid testis develop into malignancy first. Second, the maximum risk is the intra-abdominal testis. And third, there is increased risk in the contralateral testis as well. Okay. Now, apart from these, there are some certain syndromes like Klinefelter syndrome, and there can also be a familial predisposition to testicular carcinoma. Now, fourth risk factor is the intratubular germ cell neoplasm, if a person has intratubular germ cell neoplasm. And fifth is any trauma or viral infection or environmental estrogens. So basically 5 risk factors: familial predisposition, environmental exposure to estrogens, intratubular neoplasm, some syndromes, and particularly related to the person. For example, the cryptorchid testis, if there is a problem in the other testis as well. Okay. Very important thing is the classification of testicular tumors, which you can see in the image on the screen. Now let's discuss one by one. First, we'll discuss about the seminomas. This is the most common testicular tumor. Okay. This develops in the 4th decade of life. It is homogeneous in appearance. There is no hemorrhage and no necrosis. And it is related to certain factors like CD117 positive, PLAP positive, and CD30 negative. If you can remember this, well and good. If you cannot, no need to worry and panic. Okay. So seminoma, this was the classical type. Now there can be anaplastic type of seminoma as well, which has a higher mitosis rate and nuclear pleomorphism when compared to the classical type. And there can be spermatocytic seminomas as well, that is seen in older patients more than 65 years of age. And this is a slow growing seminoma which does not metastasize. So till now we have studied classical type, anaplastic type, and spermatocytic type. Now, what are the tumor markers related to seminoma? There is alpha fetoprotein, there is LDH, there is HCG, and more commonly LDH, because that is a significance of metastatic seminoma. Fine, we're done with seminoma. 3 types: anaplastic, classical, spermatocytic. Now we move on to embryonal carcinoma, which is the second most common type of testicular tumors. The first most common was seminomas, second most common is embryonal carcinoma. Now, seminoma was homogeneous in appearance, embryonal carcinoma is variegated in appearance. Seminoma had no areas of hemorrhage and necrosis, but embryonal carcinoma has areas of hemorrhage and necrosis. Embryonal carcinomas are very aggressive, and that can invade the spermatic cord and the epididymis. And the fourth point, since embryonal carcinoma develops from the totipotent cells, it can differentiate into other types of non-germ cell tumors as well. What are the tumor markers related with embryonal carcinoma? Beta HCG and alpha fetoprotein, not LDH. Not LDH. In case of seminoma, we had beta HCG, alpha fetoprotein, and LDH. Okay. So basically 4 differences between the two. 1. What is the appearance? Homogeneous variegated. Areas of hemorrhage necrosis. The tumor markers. And how much aggressive the tumor is. And how common it is. Right. Now we move on to the third type, that is yolk sac tumor. This comes in 2 forms. Pure form, that is seen in children, and mixed form, that is seen in adults. क्योंकि yolk sac तो बच्चों में ही होगा ना, इसलिए yolk sac pure from children, mixed from adults. Here the tumor marker is alpha fetoprotein and HCG. Here you can see that they have Schiller dual bodies. What are Schiller dual bodies? These are mesodermal structures which are glomerular in shape, and they have a central capillary core. This is the characteristic feature of a yolk sac tumor. That is Schiller dual bodies. What are these? These are mesodermal structures which are glomerular in shape and has a central capillary core. Fine. Now let's move on further. The fourth type of testicular tumor that we are going to do after yolk sac tumor, seminomas, and embryonal carcinoma is the choriocarcinoma. Here, the tumor marker is HCG. Let's revise once again. Seminoma had 3, alpha fetoprotein, HCG, and LDH. LDH being more common in metastatic tumors. Both embryonal carcinoma and yolk sac tumors have HCG and alpha fetoprotein and not LDH. Now, choriocarcinoma has only HCG. How will you remember this? Choriocarcinoma starts from C. HCG also has a C in it. LDH में भी C नहीं है, alpha fetoprotein में भी C नहीं है, तो इसको exclude कर दो. Now, choriocarcinoma usually presents as disseminated disease, and this dissemination can go to lungs, brain, and liver. Disseminated मतलब पता होता है ना कि concerned organ से छोड़कर बाकी अगर जगह में मिलता है तो. Let's move on to another type, that is teratomas. Teratomas are of 2 types. It can be a immature teratoma and it can be a mature teratoma. The tumor marker in case of teratoma is alpha fetoprotein. Okay. Now let's move on further. Leydig cell carcinoma. This is the most common type of non-germ cell tumor. Okay. As seminoma is the commonest germ cell tumor, this is the most common non-germ cell tumor. और इसका characteristic feature होता है Ranke crystal. Ranke crystal. Now this Ranke crystal will secrete testosterone, and that is the important point about it. We move on to the Sertoli cell tumor, which is also a non-germ cell type of tumor. This is very rare. If Leydig cell is the commonest, Sertoli cell tumor is very rare. It is associated with virilization and gynecomastia. Other type of non-germ cell tumors can be fibrosa, granulosa cell tumor. Now we move on to the clinical presentation that the patient will come with. So they will complain that there is a mass. Now this is a painless testicular mass. On examination you will see that it is firm. It is non-transluminant. You can get above the swelling. And testis is not palpable separately. Also, the testicular sensation will be absent. So you basically get a painless testicular mass which is firm, non-transluminant. You can get above the swelling, but the testis is not palpable separately and the testicular sensation is also lost. Second feature is pain. This is an acute testicular pain that is either due to infarction or hemorrhage. So first chief complaint is the lump or the mass. Second chief complaint is the testicular pain. There can be the presence of symptomatic lymph node metastasis, which can present with like back pain or lower limb edema. Now this lower limb edema due to IVC compression can occur. Suppose there is an enlarged lymph nodes in that area, or if there is abdominal mass. So basically that will compress the IVC and that will cause lower limb edema. Now, after symptomatic local metastasis, there can be distant metastasis as well. And the features related are, if the metastasis goes to the lungs, you can have dyspnea, cough, hemoptysis. If it goes to CNS, you can have headaches, PND and seizures. And if the distant meds goes to liver, there can be increased bilirubin and that will be manifested as jaundice. Other endocrine effects the patient can have is decreased fertility, and the patient can also have gynecomastia. Now you know what testicular tumors are, what are the risk factors, what are the types, and what the presentation of a patient will be. Now, let's evaluate a case of testicular tumor. First, you have to do a scrotal USG to see the mass. Second, you go for some tumor markers test like alpha-fetoprotein, LDH, HCG. Needless to say about that. But what you should remember is the half-life of these. Alpha-fetoprotein has a half-life of 5 to 7 days. LDH has a half-life of 24 to 36 hours. And the half-life of HCG is variable. Now, when to test for these tumor markers? That is an important thing. Once you will test when the patient is presented to you and you suspect testicular tumor. Once you will test 1 week after orchidectomy. And then you will test at regular intervals for surveillance and follow-up. Now the question is, why do you test after 1 week of orchidopexy? To see whether the testicular tumor markers level have gone down and whether the approach is correct or not. Third, you will do radical inguinal laparoscopy that is used for initial diagnosis, and it is a therapeutic procedure of choice as well. Fourth, obviously you have to look for metastasis. For that you can do chest x-ray for metastasis in thorax, lungs, abdominal CT and pelvis CT as well. You do CT thorax, and only for symptomatic patients you can go for bone scan or CCT brain. Now we come to the staging of testicular tumors. Clinical staging, there are 3 stages, 1, 2, 3. 1, when the disease is confined to the testis only. 2, when the regional nodes are involved. And 3, the distant metastasis is also present. So at first, inguinal orchidectomy is done. After that, the staging of the carcinoma testis is done via CT scan of the abdomen and pelvis. And finally, the treatment is according to the clinical stage. So if it is stage 1 testicular tumor, then for a seminoma testis, you first have active surveillance, that is history and physical examination follow-up 3 monthly and CT scan follow-up 3 monthly or 6 monthly. Then you have primary radiotherapy of the pelvis region and the retroperitoneum. Then you have the primary chemotherapy in which a single agent carboplatin is used. Now for a non-germ cell tumor, surveillance is not as much required as in case of seminoma testis, but here there is retroperitoneal lymph node dissection, and if the tumor is high risk, then primary chemotherapy is also done using 3 agents, that is BEP, B is bleomycin, E is etoposide, and C is P is cisplatin ka P, that is P. For stage 2 seminoma testis, you have radiotherapy and first line chemotherapy by BEP 3 cycles and only EP 4 cycles. And for non-seminoma germ cell tumor, you have primary retroperitoneal lymph node dissection with adjuvant chemotherapy. This adjuvant chemotherapy is using BEP, or you can first go for BEP 3 or 4 cycles, which is called as induction chemo, and then you can go for retroperitoneal lymph node dissection. Now, the treatment of testicular tumors based on the stage 3. For a seminoma testis, you have to first go for chemotherapy. Either you use EP 4 cycles. So with every progressive stage, you are either increasing the number of cycles or you're adding one more mode of treatment. So for chemo, you have EP 4 cycles or BEP 3 cycles. And for non-seminoma germ cell tumor, you have BEP 4 cycles, or we can go for VIP in high-risk patients. And this V includes vinblastine, I, that is ifosfamide, and P is cisplatin again. So this is the treatment of testicular tumors. First, inguinal orchidectomy, go for CT scan, do the staging. According to the stage and according to the type of testicular tumor, the treatment will vary.